Thank you, chairpersons. Thank you, Dr. Reddy and team for the kind invite. My mandate is to talk to you about plasma exchange in the setting of ACLF, and I'll try and share our experience. Looks like the slides have changed. Before I start with our experience, it all started with the ARC database and Ashok Chowdhury and Raki Maiwal's group, where plasma exchange, the first set of results were looked at. But when we look carefully at that database, it's important to realize that the patients chosen for plasma exchange, the exclusion was active sepsis, hemodynamic instability, or multi-organ failure. Most of these patients were managed in the ICU and some of them in the wards. And 94 of them underwent PLEX and about 25 did other therapies. Most of these patients were alcohol, and none of these patients, at least in the PLEX group, had steroids. They were able to show that there was a reduced mortality at day 30, and there was an amelioration of the systemic inflammatory response and prevention to multi-organ failure. With that, I go to our initial experience, small experience, where we looked at low volume plasma exchange with low dose steroids in alcohol ACLF. And in this group as well, the exclusion included active infections, those who had bleeds, and hypotension. So again, these were very sick patients. You can see the Madry's discriminant was high, but what we followed was a low volume, that's half plasma volume, minimum sessions, and low dose steroids, which was at that point 10 to 20 milligrams a day. And we were able to show that there was a better 30 and 90-day survival when compared to a standard medical treatment group. With that, we looked further and looked specifically at using the centrifugal technique along with low dose steroid. So it's a busy slide, but if you look at the bottom, it was a centrifugal technique compared to a standard medical arm, and a centrifugal technique compared with a membranous plasma exchange technique. Now, again, these were all sick patients, as you can see from the discriminant function and the MELD score. For both, when you look at, this is the C-plex versus SMT, and this is the C-plex versus the M-plex, that's the membranous group. As could be expected, the centrifugal technique had a low flow rate, about 25 to 35 mils per minute, as opposed to 125 mils per minute for the membranous plex. The processed volume again was much lower in the centrifugal plex group. The duration of plex, because it was low volume, was not too different. That's interesting. And as expected, the plasma removal efficiency with centrifugal is higher. And we were able to show in this small series that when compared to standard medical therapy and when C-plex was compared to M-plex, there was a difference in the mortality at day 90, and that continued when followed up for 1 year, but these were small numbers. So at that point, we proposed that in ACLF, the higher grades of ACLF obviously are very sick patients, likelihood of hypotension, multi-organ failure, sepsis is higher, and they must be referred and considered for urgent liver transplant. However, in the earlier grades, you could consider starting with plasma exchange, and in those who don't sort of, or who develop further and go on to a greater level of sickness, would obviously then be considered for liver transplant. With that, I go to a recent meta-analysis, and again, Dr. Ashok was kindly there on this paper. These were overall about 5,000 ACLF patients, of which about half of them had plasma exchange, 23 studies, 4 of them were RCTs. In the flow diagram, it's more to show that of these 23 odd studies, About 14 of them were from China and 4 of them were from India. So this is the forest plot showing that at 30 days there was an improvement in mortality and favored plasma exchange when we compared it to an SMT. Remember that in this entire group, only about 2% of them underwent liver transplant. So essentially you were looking at native liver survival as opposed to transplant-free survival. The same result at 30-day result was seen at 90 days. And when you looked at the 4 RCTs, these were the Chinese RCTs, again you favored Plex at 90 days. If you looked at 1 year, these were about 15 studies, again there was a in favor of Plex. When you compared the techniques, the plasma exchanges on the top and the other alternate liver support systems below, again in this meta-analysis there was no difference. And whatever definition you took for ACLF, this is before Kyoto, so whether it is Arapacil or ECIL, there was no difference, and again it favored Plex. What were the side effects or adverse effects reported? As expected, on the top were allergic reactions, probably related to albumin or FFP, sepsis and new infection, 2.4 and 3.4% was noted. Hypotension was noted, but that's probably likely related to the technique used. And TRALI or transfusion associated acute lung injury was seen in 1.4%. In the ALF setting, our group has shown that TRALI is not an issue with low volume plasma exchange. So the key points are that plasma exchange improved survival at 30 days, 90 days, and probably at 1 year. It was seen across all definitions of ACLF, any etiology of ACLF. Remember, this was mainly alcohol and there was hepatitis B, but from the Chinese groups, irrespective of the technique of Plex and the volume of Plex. However, the quality of data as seen is restricted, as the majority, there were not enough RCTs, and most of the studies, or almost entirely, it was from Asia and 4 from India. This is just a small sample to say of what we are working on. How do we know when to give up and when not to proceed further with continuing Plex? In the ALF setting with rodenticide, we have shown that a 20% delta drop of bilirubin is highly determines outcome. Here was some preliminary work which we are still working on, showing that a delta decline in bilirubin associated with the INR may have a role, and hopefully we will have more data on this, because that is then becomes important in helping us decide when can we continue with plasma exchange, when should we stop, when should we not even consider it. Similar data has been shown earlier by other groups in ACLF with regard to plasma exchange, and I was able to find this showing the similar result in the pediatric population as well. Just one line to remind ourselves, if you look on the left of your screen, in health, we all have physiological plasma exchange going on every second within the liver. And when there is an endothelial injury and the endothelium puffs up, blocks, then you have a congestion, and with the congestion there's ischemia to the hepatocytes. And a little bit of that is shown in this EM picture here, where you can see the deformed RBCs blocking the sinusoidal lumen, and indeed a macrophage trying to eat up an RBC. So in a nutshell, what seems to have worked for us in a select group of patients is that we used a centrifugal technique. We depended on low volume. We tried and did as less sessions as possible, and the flow rates by the centrifugal technique were low, and we used low dose steroids as an anti-inflammatory mechanism. Thank you.
Thank you, sir. It's a wonderful talk. For your paper on low volume plasma exchange plus low volume steroid, is there any difference in your group that you have seen between low volume or normal volume in ACLF?
So I'm unable to give you that data. I think Anand Kulkarni's group has looked as high volume versus standard volume.
That is in ALF. That is in ALF. I'm discussing about the ACLF.
Since we have used only low volume, I'm unable to truthfully tell you that. I don't think that there is data. I hope it comes out.
Okay. Any questions from the audience?
Sir, very nice talk. Do you have any experience regarding plasma exchange in scrub typhus induced ALF or dengue fever associated ALF?
So that's an excellent question, and I wish my boss, Dr. Eapen, was there. He would have been smiling and given you a prize for that. So while again we don't have published data from our side, there are, as you know, case reports showing that in the setting of scrub typhus or indeed in dengue, that there is a role for plasma exchange. I would only say that the concept of the traffic jam, anything that ameliorates that and helps the liver regenerate, the native liver regenerate, that would be good.
In the last couple of months, we have treated almost 4 patients, sir. All are scrub typhus induced ALF. Out of them, 3 survived very well with only 1 session, but 1 patient succumbed to death. So just I want to know regarding, have you ever used low volume or high volume or membrane or centrifugal type?
Yeah, so again, I can't answer that truthfully. Okay. I'm sure a few cases may have been done by our medical units, but we have not analyzed it. Maybe Ashok can add on.
Supplement. The plasma exchange mostly now preferred is the centrifugal, like membrane is less favored now. And 2, it is irrespective of etiology, because it is crop typhus or dengue, that does not make any difference if we are going to go for. So that's why I think, and then second is the patient hemodynamic status. What we see the ACLF patients, we do normal or low volume, because high volume as described, most of the Indian patients don't tolerate. So it is a normal volume or the low volume plaques we go for centrifugal and irrespective of the etiology. That is a routine program. No more questions? Yeah.
Hi, Dr. Uday. Thank you for the talk. Just for our understanding, can you tell us why there is a difference between membranous and centrifugal plasma exchange? What is the difference and why is one better than the other?
It's hypothetical at this point, and we were able to show that for alcohol ACLF, though we were not able to show that for our rodenticide ALF. My own personal feeling, and forgive me for saying my own personal feeling, is that a membranous technique, by the fact that it is high flow, causes subtle fluxes which our liver patients, especially the ACLF patients, just don't tolerate. And my ICU colleagues may back me on that. So I have a feeling that is why a centrifugal technique, being very gentle and slow, is more sort of tolerogenic to the body, but it's hypothetical at this point. But we have found that it works, and very strangely we started it only because the centrifugal machine can be wheeled into a ward. You don't need any RO lines, you don't need to bother about it. So it was an extremely easy to do, just connect it, finish it, and then, it's like the Hero Honda ad, fill it, shut it, forget it.
Thank you.